Hello, my name is Julie Fritz. I'm here to present on pragmatic and embedded trials and talk about strategies for generating evidence from the real world using these procedures. As an outline of what I want to cover today, I want to provide a little bit of historical context for the idea of pragmatic trials and where that came from. Talk about some of the reasons why pragmatic trials have relevance today and in the past. Discuss what makes a trial pragmatic, touch a little bit on research designs and some ethics and regulatory considerations that are unique to this type of research. With respect to the historical context, the first mention of the term pragmatic trial came in this interesting paper from all the way back in 1967. And for further context on this, randomized clinical trials as a way of understanding treatment effectiveness really only gained precedence in 1948 and the late 1940s. So this is soon after the clinical trial enterprise, if you will, was becoming the predominant way of establishing evidence. And these two authors already recognized a distinction that was important to consider when conducting randomized trials. And they used the term pragmatic trial and referenced that against an explanatory trial as having different purposes. And making the point that many trials already at this time were taking an explanatory attitude, that they were designed to specifically and narrowly address a causal hypothesis, often about mechanisms, and were not aimed at understanding clinical decisions and choices that occur in the real world of clinical care. And this is the domain of pragmatic trials. So even at the very onset of the use of randomized trials as a design, this tension was already evident, at least to some researchers. And they noted even then that most of the trials that had been done had taken this explanatory approach, even though there were many times where a more pragmatic approach to the research would have been justifiable. And if we fast forward a bit, the next time that there was a great deal of interest growing in what we now understand to be pragmatic clinical trials really came about around the Recovery Act and the commitment to comparative effectiveness research that grew out of that. So you see the dates here on a couple of additional editorials from this time that, again, were recognizing the same concern, that randomized trials often have limited relevance to clinical practice, and specifically because they're not designed with informing clinical choices at the front of people's minds. So again, this is from the early 2000s, recognizing that pragmatic clinical trials have some unique attributes. And in this particular paper, the key characteristics of pragmatic trials were laid out, and they're enumerated there 1 through 4. That as opposed to other randomized clinical trials, that pragmatic trials have clinically relevant alternative interventions, that they include diverse patient populations in their research, that they're intentional about recruiting participants from heterogeneous settings, and they collect data on a broad range of health outcomes. And again, you can see the statements here from these authors who were leaders in HRQ and the FDA on the need to expand pragmatic trials, and that it requires a different type of infrastructure as well as funding in order to make these types of trials a reality. And I'll just add to this historical perspective a more recent example from 2017 in the 21st Century Cures Act. And how this fits into our conversation is one aspect of this particular legislation was requiring the FDA to establish a program to use what the term at the FDA, real world evidence. And this is a similar initiative to recognize that support for drugs and devices should also come from sources that reflect routine clinical care and not strictly from traditional clinical trials. And finally, the advance of electronic health records and the use of technology in healthcare in the last decade or so has given us another term that's important to define, and that is embedded pragmatic clinical trials. So this is a phrase you'll see used now quite a bit. The idea of an embedded pragmatic trial is that the infrastructure and the data collection relies heavily on digital data that's available in the routine practice of healthcare. So in the circles outlined below as key components of an embedded or an ePCT, you see some of the same things that we looked at previously in the editorial from 2003, but that focus on data collection through the EHR in healthcare settings is now something that's a reality that would have been challenging 20 years ago. And I think it's also useful to put the discussion of pragmatic clinical trials into an overall translational research framework, just to understand where this particular type of research fits in a translational pipeline. So you can see really most PCTs, comparative effectiveness research, fit into a translation to practice or T3 domain, and have a lot of connection and overlap with dissemination and implementation research, which is often an aspect of pragmatic trials that's of particular interest. But we place pragmatic trials in this position as a follow-on to studies that establish efficacy and effectiveness, and then pragmatic clinical trials that look at the ability of interventions to have an effect under realistic conditions. That's really the domain of PCTs. So why all this emphasis on pragmatic clinical trials? There's a couple of key reasons. Some of these, I think, certainly will be familiar to you. We talk a lot in both clinical practice and in research about evidence practice gaps, and that it takes a long and extended period of time for research to impact practice, and it does so in a very incomplete manner. So you may have heard these statistics about 17 years for 14% of research to impact patients. That's frankly not a very evidence-based statement, but it makes a point that really is true in terms of a slow and inconsistent process of bringing research discoveries into practice. So pragmatic trials hold out some hope that gap can be narrowed by going to the settings where clinical care occurs. Further rationale for the need for pragmatic trials is something that's often termed an evidence paradox. And my own research deals primarily with people who have low back pain. So I use an example here in my world of what's meant by an evidence paradox. So on the left-hand side of the screen, this is data from the Cochrane collaboration, and this is the number of clinical trials published that are studying exercise as a therapy for chronic low back pain. And you can see it's an exponential growth curve from the time that I started doing research till now. So we have a multitude of clinical trials that address this question. But on the right-hand side of the screen, what you'll see is a table from a systematic review conducted recently by the AHRQ, which is comparing other commonly used modalities to exercise. And what I've highlighted is that in a lot of these boxes in this rubric, there is no evidence. So we have all these clinical trials, but they're not addressing these important clinical questions about which treatments are most effective. And this is the paradox. A large number of trials, yet systematic reviews often cite a lack of evidence, which suggests to us as researchers that we're not doing something right if our goal is to impact practice or provide information that's translatable into practice. In addition, there's concerns in the way that clinical trials are done with respect to generalizability. So the graph that's shown here is from a systematic review of clinical trials done in mental health, cardiology, and oncology, and the percentage of participants that were excluded, potential participants, in these trials. And what you see is that there's a lot of these studies that are excluding at least half of the people that might be otherwise enrolled in the trial. And not surprisingly, and I think this would be true in rehabilitation trials broadly as well, in general, people who enter trials have a very different risk population and profile because people who have more complex medical conditions or are more elderly, those are the individuals that are often being excluded. And we as researchers recognize this. An interesting point that this particular review made is that the majority of these studies actually state that they're concerned that their sample is not representative of real world patients. And this is obviously a primary concern that motivates conducting more pragmatic research. Here's another example of this concern about generalizability. This is data from the FDA from a few years ago on looking at the prevalence of diabetes based on race and ethnicity in the United States, and then the trial participant breakdown with respect to race and ethnicity across almost 8,000 participants. And you can see the obvious mismatch here. And this is a concern in terms of understanding the effectiveness of interventions in diverse populations. So what exactly is pragmatism? If you've done a little bit of work in this area, you'll recognize this wheel that's called the Preci-2 wheel. And what this diagram shows is 9 different elements of study designs that can be thought of as more or less pragmatic or explanatory. And I think this is a really useful tool for thinking about what makes a study more or less pragmatic. And it's certainly a useful tool as a researcher when designing or reporting a protocol for a study, which is intended to be pragmatic, to really think through how, as a researcher, I'm dealing with these various elements of the design of any particular clinical trial. So I want to just kind of very briefly break these down a little bit and think about this spectrum of explanatory to pragmatic within these domains that are outlined by the Preci tool. And I think it's important to note a couple things here before going into the specifics. One is this idea of a pragmatic trial versus an explanatory trial really is a spectrum. It's not a dichotomized category that you put a particular study element into. The second, and this will come up again and again, is it may not be the goal of any particular study to be as pragmatic as absolutely possible. It may not be possible to do that, and it may not be the goal to do that. But what this exercise really helps is to understand the decisions that you're making about a research design and whether it meets the need for pragmatism that's really important to the research question. So what are the domains that make a study more or less pragmatic? Well, the first one pictured here is eligibility, or who is selected to participate. A pragmatic study basically takes people like those in clinical practice. A more explanatory trial, as we already saw in the previous example, excludes the more challenging or difficult patients who may be less likely to respond. Second domain listed here is recruitment. How are participants brought into the trial? A pragmatic approach recruits people from the settings where care normally occurs and doesn't use extraordinary inducements, as we often do in explanatory research, to encourage people to participate. So paying people to be in a clinical trial is not a pragmatic approach. Third domain listed here is the organization, or the expertise and the resources that are needed to deliver an intervention. A pragmatic strategy should work to embed the research into the workflow of a routine clinical practice and use typical resources available to deliver the treatment. What we see in more explanatory trials is that patients are treated outside of the clinical workflow, possibly in a different physical space, sometimes within the same physical space, but there's set aside appointments or longer time. There are accommodations made for research participants that are not like the normal patient, if you will. It may also be that only very highly trained certified specialist providers are allowed to provide care. That would be a more explanatory approach. The setting is an important consideration. A pragmatic approach uses those that are similar to routine practice versus very specialized, highly academic settings. And then the next two domains that are listed here are really relevant and important, particularly I think in rehabilitation interventions, to think about how pragmatic you want to be in a study and how to interpret the findings of various studies. So one is flexibility that relates to the delivery of the intervention and how much provider discretion is permitted versus being highly protocolized, highly monitored, and highly standardized, which is more explanatory. And this is a real challenge for rehabilitation interventions to find the right balance in any particular study between how much you want to standardize and protocolize versus allowing for clinicians to do what they do under real circumstances, which is to exercise degrees of discretion. The second flexibility domain is focused on the participant and what sort of procedures are in place to encourage adherence from the participant. A pragmatic study would really use nothing beyond what's typical in routine care. So if a patient misses an appointment, you might call them. That often happens in clinical practice. But an explanatory approach would go beyond that and often uses incentives to promote adherence, like financial remuneration. And then a couple of final domains. One is the follow-up. How closely are participants followed and what kind of data is collected? So a pragmatic approach, to the greatest extent possible, wants to rely on administrative data sources, things that are collected in routine care anyways. This is also an area that can be challenging in rehabilitation populations if the practice setting doesn't collect patient-reported outcomes or other outcomes that are really relevant to understanding effectiveness. It's also a challenge in the desire to have a long-term follow-up, where that may not be part of the routine care pattern and has to be set up as part of a research study. The primary outcome is an important domain. How relevant is it to participants? Or are surrogate mechanistic outcomes being focused on? And then many of us who live in the research world understand this distinction in terms of how the analysis is handled and whether an intention to treat principle is used, which recognizes that regardless of adherence of participants, they need to be reflected in the outcomes of a study. So let me give you an example of the precis from a trial that I'm involved with that is a pragmatic trial that's looking at a stepped care management protocol for low back pain that happens to be being done in the military health system. For context, this trial is part of a collaboratory that's working on a variety of pragmatic clinical trials in both the DoD and VA. So you can see how this wheel is often used to give a snapshot of how pragmatic the study is. And like most studies, we're not perfectly pragmatic on every aspect. And, there are various reasons in terms of the specifics of our research question why. I'll highlight just a couple. The domain of follow-up is less pragmatic. And the reason why in this specific case is similar to what I mentioned previously, which is we needed to get long-term follow-ups on patients. We needed to get patient-reported outcomes that are typical in low back pain research, but are not part of standard care. So we had to set up more frequent and extra efforts to get outcome measures that weren't available electronically. The other domain where we scored a 3, which is less pragmatic, is flexibility in the delivery of the intervention. Again, I mentioned this, but we protocolized our interventions to a point to guide the delivery, to be able to promote replicability of what we were doing. That's a less pragmatic approach than just leaving complete provider discretion as the way we delivered care. And our experience is similar to a lot of pragmatic trials that deal with, in this case, pain populations, although I suspect this is true broadly of rehabilitation populations, and behavioral or multimodal therapies like physical therapy or occupational therapy or rehabilitation in general. So this was a recently published systematic review of pragmatic trials where they looked at the PRECISE scores across a large number of pragmatic trials. Interestingly, this particular review assessed the reliability, the inter-rater reliability of making these judgments, which is an interesting question because this is very much a self-reported exercise in most instances. And you can see the ICC was good, was pretty high, but certainly not perfect. So there's obviously judgment that goes into this. But you can see that the domains that were least pragmatic were two that I just mentioned: the follow-up domain, the flexibility and delivery domain, as well as recruitment. So I'll just highlight a couple of the things that make a study less pragmatic that we often see in studies that are working with rehabilitation populations. So with respect to recruitment, the most common less than pragmatic factors that we often see is recruiting from the general community instead of a clinical population through things like media advertising. And then using incentives to enroll. It can be cash payments, it might be things like childcare. If that's not a part of what routine care looks like, then that's a less than pragmatic approach. And again, there may be absolutely understandable reasons why a particular study does these things, but these are common variables that detract from pragmatism. With respect to the follow-up, we noted this already, that visits are more frequent, follow-up visits, that is, more extensive data are collected, more time is allowed for sessions. These are things that detract from pragmatism. With respect to the organization, this is an area where rehabilitation pragmatic trials often have to strike a balance in just how pragmatic they need to be. The things that tend to reduce pragmatism is increasing your staffing, because if we are doing a pragmatic trial and there are long waits to get into care, it may be difficult to get to the effectiveness of the intervention itself if people can't access care. This is becoming an increasing concern in my health system and some of the pragmatic trials we're running, and I suspect yours as well. How much additional training, minimum levels of expertise, specialty certification. You know, these are, again, we strike a balance in pragmatic trials of making sure that clinicians are appropriately trained to deliver what the treatment that we want to study, recognizing that training providers beyond what's normal in routine care reduces pragmatism. And this is a domain that mentioned previously in terms of the flexibility and delivery. This gets to this issue of how much do we protocolize, how much do we monitor the provider's compliance? Do we step in to address poor compliance? There are reasons to do these things, but again, they detract from a truly pragmatic study. So I'm going to shift gears a little bit now to talk about briefly about research designs and how do you actually do a pragmatic trial. And I think the most important thing to emphasize here is that good research designs to study the effectiveness of an intervention, the same principles hold when we're talking about pragmatic trials as with any other kind of clinical trial. So there's there are some methodologies and analytic procedures that are more common to PCTs, but there aren't a different set of rules. As with any kind of research question, the question itself should drive the methods. And that randomization is still the most important factor to minimize the likelihood of confounding and bias, particularly selection bias. But pragmatic trials raise some additional considerations, particularly around randomization and minimizing bias that other trials can avoid because they're not attempting to take place in routine care settings. And we'll talk a little bit about that. So this is often the way we break out the most common designs used in pragmatic trials. So you can think about who's the unit of randomization and on what level are we delivering the intervention. So maybe what we might think of as a traditional clinical trial most often randomizes individual participants and intervenes individually on those persons. And we would call that an individually randomized trial. Now, in pragmatic studies, sometimes treatments are delivered to groups of people, group exercise classes, support groups, other kind of group-based therapies. And in this case, we may be able to randomize individual people, but the level of the intervention is group. And then there are times where we're not able to actually randomize individual persons. We'll talk a little bit about why that might be the case. But there are often times in pragmatic trials where we randomize groups to a group level intervention. So this might be a clinic that's randomized to receive a certain kind of training for all the therapists who work in the clinic setting, or a hospital. We obviously can't randomize individual participants in those kinds of circumstances. And then finally, a special case of a group randomized trial is something called a stepped wedge group randomized trial. And the key difference here is whether all groups start at once or whether that's done in a stepped manner. And I'll show you an example of what that means. So back to individual randomization. So this is, again, what maybe many of us are most familiar with. And the key point to take away here is there are several reasons why, but this is when you can do this design, it's the best design to choose. So for many behavioral pragmatic trials dealing with rehabilitation populations, this is completely possible and is the design of choice, where we can randomize individual patients and then treat them individually based on their randomization assignment. The reasons why this is preferable is it reduces to the greatest extent possible that likelihood of a selection bias. It's most efficient in terms of how many participants you need, but it's not always possible in pragmatic trials because of contamination. So, for example, it's hard to ask an individual therapist to do one kind of treatment for one patient and then train them not to do that treatment with another patient. So that might be a reason why individual treatment isn't realistic. Or patients may naturally cluster before they're randomized, and individually randomizing them and expecting them not to talk to each other is not realistic. So sometimes we can individually randomize, but the treatment occurs in groups. This is maybe more frequent in psychological-based therapies, but also occurs in other rehabilitation populations where interventions are provided to groups of patients. So the advantage here of the individual randomization is that it still reduces the likelihood of baseline imbalances, but we lose efficiency because of the clustering of patients in their treatment groups. And logistically, sometimes this can be challenging. If you're trying to form a group to start treatment and you have to make people wait until the group has enough participants, there are times where that's just not very realistic or very patient-centered. Cluster randomized trials are fairly common in pragmatic research. And these are most typical when the intervention is operating at a group level, like a community or a hospital or a clinic or a provider. And it's not realistic to think of delivering care to individuals without a very high risk of contamination. So if we have therapists who work in the same clinic and we've trained some to do one kind of technique and some to do something else, but they're working in the same space and they're talking to each other, it's not very realistic that there's not going to be contamination. So this is a common design. It can be a little challenging to make sure that you have enough units, enough clusters to randomize. And especially in a situation where there's only a few randomizable clusters, even though they're being randomly assigned, the chance for baseline imbalances becomes higher. So that's a downside here. Another challenge with this design is sometimes the ethics of consenting. If a clinic is randomized to a certain procedure and you as a patient come into that clinic to receive care, should you be told that there's a research study going on and provide your consent? Or is that something for which informed consent can be waived? We'll talk about that in a moment, but it can raise these kinds of ethical concerns. And finally, a stepped wedge cluster randomized design. And this is really the same as the previous slide, but the randomization or the implementation, I should say, of the intervention occurs in this stepped procedure. Often the reason why we do this is it's not ethical or appropriate to not make sure that all groups eventually get treatment. And often logistically, if you're really ramping up or starting a treatment that's very complicated, to do it across all the sites in your study at the same time is hard. But this study design really comes with some challenges, and I think COVID really highlighted that. So, you can imagine that if you're in the middle of this type of study and something as disruptive as COVID comes along, it can be hard to interpret, what usual care looks like once COVID hits. You also may have treatments where they're very effective early on and then they wane. And that time varying intervention effect can really be a confounder in this design as well. So stepped wedge designs are sometimes useful for various reasons, but they come with some specific challenges. So if we think about this in terms of how to design a pragmatic study, the first question to ask is there a strong rationale for not using individual randomization to individual treatments? And if the answer is there is no strong rationale for not doing that, then that's the best design. If patients are receiving treatment in a group or they share the same clinician, then it's probably necessary to do a group treatment because of that clustering. If there's a strong rationale for not randomizing individual participants, then the question becomes, can you roll out all the groups in the intervention at once, or do you need to do it in steps? The preference is to do it all at once, so you have a group randomized trial. But if there is a rationale for doing it in steps, then it becomes a stepped wedge. And let me just conclude with a couple of comments about ethics and regulatory considerations. And I think this is really an area where there's a lot of work being done. Based on the growth in pragmatic trials, there's some gray areas here about what best practices are in the interest of patients. So I think there's a lot of, this is a work in progress. So the activities that occur in pragmatic trials that are really embedded within a healthcare system are often conducted with IRB-approved waivers or alterations of consent. So consent may not be required, or alterations may occur, like giving broad notification to patients or more brief oral consent processes, etc. But often the way we traditionally think about consent, where you sit down with a researcher, read a consent form, and provide a signature, that's not often realistic or necessary in pragmatic trials. But how do we protect subjects while recognizing that? It also can be, at times, a bit challenging to even determine exactly who is a research subject in a pragmatic trial. So if the intervention is going on at the level of a provider or a clinic, how do we think about consent at that level? There also may be instances where caregivers or family members or people connected to the patient become impacted by the research and at some point may even be thought of as subjects. And how to think about providers is a particularly interesting area here. So clinicians, are they just conducting research practices, or are they engaged in research? Do they need to be on the IRB protocol, complete human subjects trainings? Are they becoming researchers when this kind of work is done? It can be unclear. So a couple of examples. These are from the NIH Pragmatic Trials Collaboratory. I've used several slides and figures that come from the Pragmatic Trials Collaboratory. They have great resources. They're really an authority on methods for pragmatic trials. So this particular study is interesting. It's a step wedge design, but I want you to think about kind of the ethics that are going on here. So the basic idea here was to change the radiology report for lumbar imaging to give modality appropriate benchmarking. In other words, to say the changes that are shown on this MRI for someone who's 75 years old are consistent with what are typically seen for this age group or something like that. To try to decrease catastrophizing and over emphasis on what are common results. So once a clinic was brought on board to the trial, all patients who got lumbar imaging at the clinic got this report. So, you know, are the providers in that clinic, are they able to opt out? Do they have to provide consent? Do the patients have to provide consent? The way this study handled it was that all the sites granted waivers of consent for patients and clinicians. So this just happened in the background. It became part of the standard reporting. But there was one site who was concerned about the providers and wanted to make sure that they were told about the results at the end of the study. So again, you see that it's not always clear about exactly how to handle some of these challenges. This is a pragmatic study in the same collaboratory that I'm leading here in Utah. And this particular study, I've tried to display the design here, is an individually randomized trial where patients are referred to our study team from federally qualified health centers around Utah. So we get an electronic referral. We reach out to the patient and offer them the opportunity to enroll in the study. Now here, you know, clearly we need to get the consent of the patient to let them know that we're delivering the treatment a little bit differently in different arms, and we need their consent. But this is a telehealth intervention, so written consent is impractical, would be very difficult to do. So we have an alteration of consent granted by the IRB for oral consent. And the physical therapists in this study, unlike the clinicians in the previous study, had to be specifically trained to provide interventions in different ways. We've actually made them able to consent participants. So they are clearly engaged in research and they're part of our study team and they've gone through human subjects training and are subject to all the regulatory compliance. But this is very different than the first example. And just for context, here's our Preci diagram for this particular study. A little less pragmatic than some of the other studies we've looked at, as you might imagine from what I've already explained. So I just want to conclude by calling your attention to a number of initiatives going on where pragmatic trials, many of which relate to rehabilitation populations, are being conducted, and there's really great resources available. So I mentioned the NIH Pragmatic Trials Collaboratory as a source of information. I really recommend their webpage. They have a living textbook related to pragmatic trials. It's a fantastic resource. The Pain Management Collaboratory, I also referenced this in the talk. This is a VA, DOD, NIH collaborative where every trial in this collaboratory is looking at non-pharmacologic pain management strategies, often with rehabilitation providers be very much of interest to probably people who attend these seminars. The NIH HEAL initiative also has pragmatic trials as part of its portfolio, dealing specifically with pain management and opioid addiction. The previous study that I showed you is part of that. And you can see other groups listed here that are focusing more and more on pragmatic research. PCORI probably deserves a comment, as well as a real key funder for this type of research. So as I mentioned, the NIH Pragmatic Trials Collaboratory, these are studies that are funded under HEAL, many of which are led by rehabilitation providers that are asking very pragmatic questions about the rehabilitation of people with chronic pain. And the Pain Management Collaboratory, also in the area of chronic pain, doing some really interesting pragmatic studies in the VA or in the military health system. So with that, I'll conclude, and I welcome your questions. Thank you.